So thank you very much for joining us today. We are very excited today to present to you the next JASE Associate Editor Corner with Dr. Mark Friedberg. Dr. Friedberg is one of the Associate Editors at JASE and will speak to us today about his involvement within JASE, his research career, and his thoughts about the future of echocardiography. Welcome, Dr. Friedberg.
Thank you very much, Jordan. Good to be here.
So to get started, I just wanted to give a sense for some of our listeners of what got you interested in echocardiography, and specifically how you got to the current position that you're in, and what is your current role and breakdown of roles.
Right, so I really became interested in echocardiography as a pediatric cardiology fellow at Stanford quite early on in my fellowship. And I remember Dr. Norm Silverman taking me in the first or second year of my fellowship to the ASE conference, which was the scientific sessions, which was in Seattle at that time. And since then, which was in 2006 or 2002 or 3, I have not missed an ASE scientific sessions in all those years. So I became pretty passionate about echocardiography. I did a subspecialty year in echocardiography and in research. I combined my third and fourth years of fellowship to do that. And that really, I think, guided my career in combining clinical pediatric cardiology, clinical echocardiography, as well as research, which relies heavily on echocardiography. And then, attending ASE and getting to meet a lot of the community, learn a lot about echo, about the people, and eventually growing in the organization. I became involved in the Pediatric Council, as it was called at that time, rather than steering committee, as I think it's called today. Really, the people there were my role models, and some of the organizers of the pediatric track at the scientific sessions, and the people I looked up to, and just started, getting to know people, and then continuing my own academic work, and would look really forward every year to participating in ASE, and then in years to come participating in EuroEcho as well. And that's been a really fun aspect that I think a lot of the pediatric cardiology community has appreciated, the collaboration between the European and North American societies and communities. So I'll say that all in one breath. And then at ASE, and through my work at the council for several years, I was nominated or asked to consider the pediatric track chair or first co-chair and then chair role, which I did initially with Pierce Barker, and just loved working with Pierce and learning about that. And then subsequently, when I became the track chair the year afterwards, I did that with Craig Fleischman, who's now actually head of the steering committee. So, and obviously those are just two of the people, but there were many, many people who contributed, who gave of their time, and really made that a home, a community within ASE. So through that, I think, I had been submitting to JASE for many years as an author, and still do, and started reviewing quite a bit for JASE. And Dr. Alan Perlman then asked if I would join the editorial board, and I did several stints as a reviewer, or as an editorial board member. And that I learned a lot from that, and obviously writing papers and reviewing papers, and you see both sides of it, and that's an important point. And then eventually, I think when there was a call out for an associate editor, an email came by, I thought that maybe it's time to try that and see what that entails. So I think I've been on the editorial board now almost 2 years, and Dr. Picard, had asked me and brought me on board, and working with him and Dr. Moravi has been an absolute pleasure. So that's how I got to my current position.
Well, that's fabulous, and it's obviously great to see that kind of dedication and commitment to both the field of echocardiography as a whole and also ASC as a society at the helm of sort of leading this effort. And of course, that dovetails very well with your involvement with JASE as a scientific arm of that. You mentioned a little bit about how being being an associate editor and being on that position of both reviewing and also submitting articles gives you a sort of a unique vantage point. Can you maybe elaborate a little bit more about what it is that allows you to be able to see, or what insights you've been able to glean in the process of doing that?
Well, I think I don't know if this answers your question directly, but the difference just between a reviewer and I think an editor position, be it associate, and I think Dr. Picard has a lot more of that responsibility, is, it's really deciding what the priority is for one article versus another. And coming from the pediatric world, or the congenital and pediatric world, I should say, because there's a lot of adult congenital echocardiography that is going on, is really, I think, a position of promoting or advocating for our field, but at the same time making sure the science is good, and three, competing with the adult papers. So when myself or one of the other pediatric associated editors is advocating for a paper, we are really competing with adult papers that may be much larger populations. Sometimes they're very good science, but this paper may be really important in our field. So it's really a balance of thinking about the bigger picture and what will be important out of all the articles that you or papers you're reviewing. Which one are you going to fight for, because you know that you're not going to get more than a certain number in, even if you would have wanted to publish more. So I think that's the different vantage point of just the author's vantage point, even the reviewer's vantage point, and the editor's vantage point.
I think that's a really interesting perspective, and it speaks to the broad sort of Big Ten philosophy within echocardiography as a whole, and how many different subdisciplines really there are within echocardiography. And thinking about this is not only sort of the pediatrics, but also the perioperative roles and then now sort of veterinary medicine. I think the tent is expanding, and as we sort of expand with it, that creates unique pressures, certainly for individual fields. How did you get involved with, or what specifically would interest you about echocardiography versus, for example, other parts of pediatric cardiology, and what I guess what continues to interest you in that as well?
Right. Before I delve into that question, I just want to follow up one point on the last question, if I may, because I think this is a really important point for JASE. In having to balance the balance between pediatric and adult papers, we know that pediatric papers in general get cited a lot less just because of the numbers of pediatric cardiologists versus adult cardiologists. That's really an important consideration for a journal. So I really respect JASE that gives us a place to voice our field, to promote our field. And both Dr. Perlman and Dr. Picard, which are the two editors that I've worked with, and I want to say the rest of the editorial board as well, I really appreciate, and I'm not just saying this as a cliche, their willingness to really listen to what pediatric cardiology has, and that it's important. And when we do compete with much larger papers, which are for sure going to get cited more, they still take into consideration our papers. And so that's really important. I know that's not true for all journals, and where impact factors now become a dominant kind of theme. So I think that was important to say and to put out there, if anyone's listening, that we really do appreciate as a community that support. So to your question about why I got interested in echocardiography, well, just by nature, I'm more of the non-invasive cardiology than invasive cardiology. But why specifically echocardiography is a combination of my interest in physiology and subsequent interest in cardiac function, and now specifically right ventricular function for the most part, but also the mentors that brought me into that field. I think, it's similar to having a good teacher at school, and I was fortunate to have good mentors and superb echocardiographers around me. And so my interest in physiology, where I could use a modality to visualize what we were talking about, and in pediatric cardiology, loading conditions and hemodynamics, and the combination with anatomy and congenital defects becomes critical. And that really is what drove my interest in echo. And then when I was a fellow, so this all stemmed from my first years in pediatric cardiology. Strain imaging was emerging in clinical use, and we had the first beta version of this software or of that software. And then I could really begin to interrogate myocardial function and physiology in relation to these hemodynamic and congenital defects. And so it became kind of a combined interest of the excitement of a new field, and combining it with an old field or older understandings. And the other thing that was happening at the same time with the evolution of functional imaging, of strain imaging in particular, and also cardiac resynchronization therapy in the adult world. So I got interested in that because of some of the faculty at Stanford that were kind of leading that in pediatrics. And I remember going to one of Ted Abrams' courses early on in Baltimore. They were talking about CRT and assessment of CRT by echo, and so I got into that through my interest in functional imaging and what echo could offer as insights. We thought that could offer much better insights than we previously learned about the Prospect trial, and I've been interested in that ever since. But still, it was a very exciting time and continues to be exciting, and I continue to investigate that.
That's great. And I guess, for us as, or I speak for myself as an adult echocardiographer, I do think there's a lot to be learned across the subdisciplines within echocardiography. What do you think we can learn as adult echocardiographers from pediatrics and from the study of echocardiography that's been done so far?
Yeah, I
That's a
think
big
is
question.
important. I think it's an important question because we usually think of it the other way around.
Right.
And for sure, we have learned a ton from adult echocardiography. I have personally, going into functional imaging and regional function, which wasn't a big topic in pediatrics, and I think will become and has become an ischemia, which I think drives a lot of congenital heart disease dysfunction, but we really haven't paid a lot of attention to, or not enough attention, I think. But what I think the adults can learn from pediatric cardiology and congenital cardiology is not to dismiss it. So when you see a pediatric or congenital paper, not to flip the page and go on to the next paper. But we are really a physiology laboratory, if you will, for how the heart works. So when you have, conditions such as congenital aortic stenosis and the trouble that creates for the heart early on, or multiple left side obstructive lesions, or you've got single ventricles or lesions such as hypoplastic left heart syndrome that really tell you about right ventricular function, about ventricular-ventricular interactions when you don't have one of the ventricles, or you have one that's extremely abnormal, or you have repair tetralogy of Fallot with severe pulmonary regurgitation, which is chronic in many years. I think it can provide a lot of insights on what is important for cardiac function and physiology and what affects it. And then when we repair or we treat these conditions, how that changes the function.
That's fantastic, and I think obviously there's a lot to be learned in the process, and I think a lot of insights to in the future to be gleaned. Which brings me to my next question, which is, where do you see the future of echocardiography going, in particular for pediatrics, but maybe also globally? How do you see the field changing, and how do you see the clinical practice changing along with it?
Yeah, so obviously we've all seen, regardless of if you're from a previous generation, this generation, or even the current generation, if you will, we've all seen huge changes in practice. And certainly in functional imaging, I've seen huge changes in practice. And I also do experimental cardiology or experimental work with animal models, and I use echocardiography there. And still fractional shortening is, kind of the function. And I often wonder why I bother spending so much time and effort, in my trainees measuring strain and measuring other things in the animal models. But that's kind of what's happened in the field of echo clinically. And I think there's really exciting directions going forward. And I think echo is tracking other other technological advances in other fields. So obviously, the whole area of artificial intelligence and machine learning is a very big one. It's very exciting for us to try and tackle problems that we haven't been able to solve and that are persistent, like how to assess diastolic function in children and in congenital heart disease. So if you think it's difficult in adults, we'll try to do it in a single ventricle with a Fontan circulation. And even in areas where we've made a lot of progress in functional imaging, such as in cardiomyopathies, let's say with tissue Doppler and strain and more comprehensive diastolic assessment, even there, we haven't made a lot of progress with prognostication and even outcomes, and mortality remains very, very high. Similarly with hypoplastic left heart syndrome. So one of the areas I've been interested in collaboration, with Professor Bart Bainens, who in Barcelona, is to try and combine echo parameters with clinical parameters of importance to predict outcomes and to guide management and to see who will respond and who hasn't. A lot is going on in the adult world, in similar fashion. I realize that. So we're tracking that, but I think for our field, it offers unique insights. There is fantastic work going on in 3D echo in some centers, in Edmonton, in Canada, in England, in London and in other centers. And again, the technological advances, if you can automate those processes to bring them into routine assessment, will be really exciting. And on the other hand, there's still, I think, a lot of place for what we call conventional echo, which I think is also really important not to leave that aside, and how we may use that serially or over time to predict outcomes of kids, and a lot of work in appropriate use criteria led by Dr. Sachdeva in Atlanta and others. So I think the whole spectrum and incorporating these with advances is going to be important. But I think the automation, the machine learning, in incorporating those into clinical practice with multiple other parameters, not just the echo, but the clinical information, the ECG, other imaging modalities, is going to be really powerful.
Yeah, I think that's a definitely a huge growing area, and I think there's a lot of interest in using technologies not only just to improve and speed workflow, but really to glean the insights about disease and disease states and going forward. Is there a particular article that stood out to you, or articles that have stood out to you over the last year or so that have within the pediatric literature that really think deserve a sort of special mention or note as being sort of important to the field?
Yeah, well, I'll just maybe mention three briefly that kind of are in different directions that I think are important, and how how it spans the field, and maybe just to pique people's interest from this year. One of those is a paper out of Pakistan from Babar Hassan's group. He's done fantastic work over the years, but really highlighting how exposure prenatally in fetal life to maternal preeclampsia affects vascular function and even cardiac remodeling, which we know from other studies postnatally. So, the link between prenatal events and postnatal cardiac function over the entire life of an individual. And that's another reason why adult cardiologists should pay attention to pediatric literature, is really relevant. And this was done in a if you will, they are a fantastic university, but if you will, in a low-income country or a low-resource country, and have used conventional echo in a really great way. So that was one reason I wanted to highlight it. The second reason is that there's vascular investigation there, which is, I think, still lacking in the pediatric literature. There are good very good groups doing it, but it's still not as prominent. So that was one paper. The other paper was, as I said, with a collaborator of mine, Professor Bart Bain, and so it was actually an adult paper in systemic hypertension, looking at strain patterns as well as other Doppler patterns and other clinical data and their relation to systemic hypertension and prediction of, remodeling and outcomes. And we've done similar work with the Bart in dilated cardiomyopathy, and that's what I was speaking about before, because I think it's very easy to focus on one parameter, on one quantitative parameter, peak strain, ejection fraction, or whatever it is. But there's a wealth of information in the patterns of contraction and relaxation and in the strain curves over the cardiac cycle that currently is very difficult to incorporate for the human brain into a comprehensive synthesis of information, let alone to put that together with other information. That goes back to what I was speaking before. So to me, that's really exciting research and useful research to then categorize patients into phenotype, or we all know cluster analysis of phenotypes, and look at how it may predict response to therapy or outcomes or any other outcome you're looking at. So that was a second paper I wanted to highlight. And then third, not to toot my own horn, but I was excited by an animal study that we did, a preclinical study, although we did include human data. We had years ago collected simultaneous high fidelity pressure-tipped catheter data simultaneously with echo data in the cath lab in children with pulmonary hypertension undergoing a clinically indicated cath. And I said beforehand that we are doing preclinical experimental work, and we're studying animal models of pulmonary hypertension and using echo. And obviously, we use conductance catheters in these animals as well to judge RV function. And what we found is that by combining the pressure strain variables, if you will, pressure strain loops, which is again another hot topic in the literature overall, coming out of the Oslo group for the left ventricle and now being transferred to the right ventricle, we highlighted that asymmetrical work between the free wall and the septum is a driver of injury, of fibrosis in the animal models, and of dysfunction and inefficiency in the human models. So I think we all look at a heart and we know that the heart contracts symmetrically, both between the right and the left ventricle and within the ventricles. And I think if we start paying attention to these regional inefficiencies, which create global inefficiencies, global dysfunction that we think drive outcomes in these patients, I think that's another use of echo, especially in areas like right ventricular function where we struggle to quantify it. If we can get things like myocardial work and regional myocardial work and its distribution, that may help us detect right ventricular dysfunction and failure perhaps earlier, know who at risk and why they're at risk, and perhaps target treatments better.
I think that's fantastic. And obviously there's a number of areas that we can sort of highlight as being evolving within the field of echocardiography overall. One of which I think sort of comes to mind in particular, which is point of care ultrasound. And where do you see? I mean, obviously there's the need to be able to standardize the approach and the interpretation of point of care ultrasound. But where do you see point of care ultrasound being of most relevance in the pediatric realm, and how do you see that evolving over the next sort of 5 to 10 years?
Yeah, I'm going to sidestep the question slightly. I'm actually not going to talk about point of care ultrasound. There are others that can do that better than me, although there are many areas in pediatrics where it's being implemented, emergency room, intensive care, the neonatal intensive care unit, but rather answer your question just as a true diplomat does by not answering the question. I think there can be remote care given by ultrasound. We talk about technology advances. I live in Canada, a country where a minority of the population lives in far-reaching north areas, and it's very difficult for them to get proper care, let alone to get monitoring from a tertiary care center. So, I saw at one of the ASE conferences robotic echocardiography, where a remote user controls the probe that even the patient themselves can put in the arm, or there's a local technologist that can kind of help. to me, that's a point of care, or maybe it's a remote point of care used for ultrasound. So countries like Australia, even the United States, Canada, and areas where there's uneven distribution of the population or vast geographic areas, I think that's really important. And then incorporating that into machine learning, automated algorithms to discover who's at risk, such as, let's say, in fetal echocardiography, if the obstetrician is doing a fetal ultrasound and they have automated algorithms to see who is at risk, and there's already work published on that, that's going to be a great point of care ultrasound. And the other one is, I think this will evolve perhaps, the whole thing of wearables in technology and wearable ultrasound, and whether handheld ultrasound will be done by patients with the data being automatically monitored is a second point. And thirdly, we're trying to initiate a project in the intensive care unit where we will, through these automated machine learning algorithms, teach the physicians or the staff in the ICU to acquire ultrasounds, to incorporate that with the physiologic data that's collected in the monitor on a millisecond frequency to better predict whether patients are ready for extubation or what their response to inotropes will be, and really to try and replace, in essence, what would be a virtual cardiac catheterization. So that's how I see that evolving.
It is a fascinating. I hope to live in the future that you're talking about, because that's a fascinating development. And I think obviously there's a lot of growth in this field and in others, but I think there's a particular wealth of opportunity within echo, which brings me to my last question for you, which is for anybody who's new to the field or is just starting in pediatric cardiology and is being exposed to echo, what would be your sort of word of advice in terms of getting involved in pursuing a passion within this area?
Right, thanks for that question. There are obviously a lot of ways to do it. And, I'm not pitching for ASE, but I am, going to conferences, being exposed to what's going on and really growing up in the field as it's happening, because it's changing constantly, as we've talked about, is really important. But don't forget to learn the basics. Start with the basic physiology, read the basic anatomy. It all stems from there. All these studies we're talking about have already been done by someone else with a different modality, 40 or 50 years ago. And I really think that connecting with that basic knowledge and research while evolving in the field is critical. Obviously read a lot, but also write a lot. Don't be afraid of that, going to that. It's not for everyone, but if you're going to evolve in academics, everyone should get a taste of that, even if they're going to be not going into academics afterwards. And just do what you're passionate and excited about, because you're going to spend a lot of time doing it at all hours of the day. And so you have to be passionate and driven by it. I get excited when I think about physiology and function. Something needs to excite you, and that's what you have to have that fire in your belly, so to speak.
Well, it's very clear to see the excitement when you talk about this, and I think that's inspiration for us all. So I think that unfortunately brings us to the end of our time here. But thank you, Dr. Friedberg, for all of your time, and thank you for all that you do for JASE and for echocardiography as a whole.
Thank you very much, Dr. Strom, for the opportunity and your time.